Okay, good afternoon, everyone. Today's speaker is Dr. Larry Istrail. As many of you know, Dr. Istrail is one of our hospitalists here at Fairfax Hospital, working primarily in the progressive coronary care unit. He joined Inova from his internal medicine residency in 2015 after completing medical school at Virginia Commonwealth University. In addition to Dr. Istrail's service here at Fairfax Hospital, he is an entrepreneur, author, and inventor. He founded Fio Coffee, a medical-themed coffee company honoring medical pioneers. He co-founded Photo Calorie, a web-based service to photo capture dietary intake, and he invented a digital stethoscope. He has also recently authored a book titled The POCUS Manifesto that paints an inspiring picture for the future of diagnostic medicine. Dr. Istrail is certified in point-of-care ultrasound by the Society of Hospital Medicine and the American College of Chest Physicians, and has been very active in teaching residents here the art of ultrasound, for which he has been recognized with teaching awards. So please welcome Dr. Larry Istrail.
Thank you, Rob, for having me. Can you hear me okay? All right.
I'm clear.
Great. So I'm here to talk about point-of-care ultrasound. It's something I'm passionate about and I've gotten really into in the past couple of years, and hopefully you guys by the end of this talk can see why. So we're going to cover brief history of the physical exam, very brief, and then we're going to go into lung auscultation versus ultrasound, both the evidence for it and how it works. And then we're going to talk about JVD, ultrasound versus physical exam, and then we're going to talk about cardiac exam. So, this is a non-complete summary of the history of our physical exam and some of the main contributors. So starting at the top left, obviously we have Hippocrates, who contributed a lot to bedside diagnostic medicine. One of the things I would say he's most known for, or that has carried on since his time, was what he called immediate auscultation, or putting his ear up against the chest and listening, to try to figure out what was going on. Many, many years later, we had this guy, Auenbrugger. He was from Vienna, Austria, and he was actually the son of an innkeeper. And as the story goes, he saw his dad when he was young tapping wine barrels at the hotel or the inn to try to figure out how much wine was inside the barrel. And that's supposedly his inspiration for coming up with percussion. So when he became a physician, he would tap on patients' lungs in different areas, and he would fill them up with fluid after death and try to figure out how the fluid and would change the sound. And then, about 80 or so years later, René Laennec came around, who everyone knows invented the stethoscope and also the field of mediate auscultation as compared to immediate, which is through a stethoscope as opposed to putting his ear on the chest. And then lastly, I'll include Dr. James Hope. So he was really one of the first cardiologists in the modern sense. And he really was key in characterizing valvular diseases and murmurs early on. And so that's really what I consider four of the big names in the before POCUS era, before we had ultrasound technology at the bedside. And then in the POCUS era, which I argue we're in now, there's really two names that stand out to me in the history of this field. One is on the left, Dr. Roland. He was a Dutch cardiologist and real pioneer in the field of bedside ultrasound. We'll talk about him later. But really the biggest name in this field, really what I think is the modern day René Laennec, is Dr. Lichtenstein. He's a practicing physician today in France. And as we'll see, he really pioneered whole body ultrasound, but he's most famous for his work with lung ultrasound. So I spent the last year writing this book about point of care ultrasound and how it kind of fits into the history of our physical exam. And what I found interesting was really there was kind of three themes or essential truths that I noticed. One is, whether it was Hippocrates or Laennec or Lichtenstein, it was really all about trying to augment the subjective history with objective data, however they could best do it. The second thing is that in the before POCUS era, all these exam findings were figured out by doing this exam to autopsy strategy, where basically they would listen to a patient towards the end of their life when they're hospitalized. They had no treatments back then, so the patient would basically just linger until they passed away, and then they would do an autopsy and try to figure out what those sounds were corresponding to. So because of that, they were really studying end stage patients, and because of that, as you'll see, most of the signs we have now are usually more specific but not sensitive. And the third thing is just a more broad idea is that, you know, as our technology improve in any field, but especially in diagnostic medicine, you know, the ideas and the frameworks for coming up with new techniques are limited by the technology at the time. So it really comes down to two people, in my opinion, Dr. Laennec and Dr. Lichtenstein, who have a lot in common. They're both from France. They both spent time at Necker Hospital. Like I said, Laennec used the auscultation to autopsy approach to figure out all the lung sounds we use today. His eureka moment was really kind of a modest event where he was consulted on an obese female patient, and due to modesty and just practicality, he wasn't comfortable putting his ear on the patient's chest to listen to her lungs. So he rolled up a piece of paper into a cylinder and stuck it up one side on his ear, the other side on her chest. And sure enough, he could hear her lungs. And so that's how all this really started. And then it morphed into like a wooden tube, and then eventually, obviously, into the stethoscope we have today. Lichtenstein, very similar, but 150 years later, he used insunnation or ultrasound, and he compared it to CT scans that were already done on his ICU patients to try to figure out, like, what does a pneumothorax look like on ultrasound? What does pneumonia look like? What does pulmonary edema look like? And he really pioneered the idea that you could even ultrasound a lung, which to this day, many people don't realize or appreciate. And so his eureka moment was one of his first nights in the ICU. He had a crashing patient. They did a chest x-ray and he had white out of both lungs. And he thought, he couldn't quite tell, is it pneumonia? Is it ARDS? Is it a pleural effusion? And so what he did was at midnight, when the radiologist went home, he spoke about this publicly. He goes into the radiology department, wheels the ultrasound machine into the patient's room, and he had learned some ultrasound a few years prior, and he puts the ultrasound probe on the patient's chest, and he sees that it's actually a gigantic pleural effusion compressing the lung, what he called pleural tamponade. And it was not, in fact, a pneumonia, and it was acutely treatable. And so he did a thoracentesis, drained the fluid, and the patient got better. And so that was really his kind of moment where he's like, wow, this could be very powerful. And so he's really done a lot of whole body ultrasound, but he's most famous for his work with the lung. And so what is point of care ultrasound? Basically, it's using bedside ultrasound to augment the physical exam to answer focused clinical questions. It's not full echocardiograms. It's not measuring every valve. It's asking a specific question and trying to get an immediate answer. I really think about it as inspection of the internal organs. We inspect the skin, we inspect the eyes, we listen, and we should also look inside at the organs and look at what we're trying to diagnose. And it's really about detecting or diagnosing on the spot, as opposed to trying to infer what may be happening on the inside of the body through sounds or through manifestations on the skin, things like that. So the Journal of Hospital Medicine put out kind of a position paper on what a hospitalist could reasonably be considered able to do if they're trained in point of care ultrasound. And you can see it's a vast, multi-organ thing that they should be able to do. You can look at the heart, you can look at the LV/RV size, you can look at the ejection fraction, volume status. You can diagnose pulmonary disease, which is what we'll talk about a lot today. There's also abdominal, vascular, musculoskeletal, and all sorts of other, reasons why point of care ultrasound can be so powerful. And, you could also just use it to reassure a sick mother with pneumonia, like in this case, she was pregnant and was really worried about her baby. So there's lots of uses for it, but I work primarily in the cardiac step-down unit, or the PCCU here, and we use point of care ultrasound on every patient almost every day. And I wanted to go through a CHF exam, both the traditional way we assess a patient for CHF and how it could be better or different with point of care ultrasound. So, we'll start with the lung and lower extremity exam. Of course, we're listening for crackles and we're looking for swelling. And so if we go back to 1816 in Linac's book, he wrote this 700-page book going through every possible pulmonary disease, cardiac disease. And this was in the pulmonary edema chapter. So he had a patient who was short of breath, and it was a 47-year-old female who, quote, came into the hospital a fortnight after her symptoms started, affected with edema of the superior extremities, particularly the left, dyspnea and cough, expectoration of sputa, and had anasarca increasing over her whole body. So on his physical exam, he explained that the respiration was very distinct on both sides and was accompanied by a slight crepitous rattle. He described these as fine crackling of roasting fat or the crackling of salt on hot coals, and he accurately, concluded that with very few exceptions, they indicate the presence of fluid in the bronchial tubes. And so this patient, when she passed away, they did an autopsy, and he found that where he was hearing those crackles essentially had pulmonary edema. He didn't see any evidence of pneumonia. He didn't see any, TB. And so that's basically how he figured out that pulmonary edema caused crackles. But as I was mentioning, these are end-stage patients. And so the question really comes down to, what is the diagnostic accuracy of these? How sensitive or specific are they? And now in the modern era, we have a lot of good data to answer that question. And so 200 years later, actually to the year of when Linac published his book, there was a big study in dialysis patients. And basically what they did was they took patients right before dialysis, presumably with a lot of pulmonary edema, and they scanned their chest to confirm that. And then they underwent dialysis and then did the same thing after, when they presumably had less pulmonary edema. And they looked at the physical exam findings, lower extremity edema, pulmonary crackles, and to try to see how sensitive and specific are they. And the results were not very, promising. So for detecting severe pulmonary edema, pulmonary crackles were only 9% sensitive, which is pretty shocking, but it was very, very specific, 98% in this population of dialysis patients. Same with peripheral edema. It was only about 3% sensitive, but it was 100% specific. So if they did have pulmonary edema, if they did have crackles, then you can be confident that this was related to pulmonary edema. But if they didn't, you really can't say what's going on. And so what they concluded was, this study shows that the two-time honored clinical signs like lung crackles, peripheral edema, that are universally applied to detect and monitor volume excess or fluid translocation to the tissues have unsuspectedly low sensitivity for detecting interstitial edema in a most critical organ like the lungs. Now, this was basically confirmed by many other studies. For example, in an emergency department where you have not just patients with pulmonary edema, they only found rails or crackles were 56% sensitive and 80% specific. In a study of ICU patients, it was only 30% sensitive. In another study of emergency department patients, the lung auscultation essentially didn't change the diagnosis. And in an interesting Japanese study, 70% of patients over 80 years old had lung crackle despite no pulmonary disease, and 30% of patients under 80 had crackles despite normal high-resolution CT scans. So in 2020, in Nature, they published a meta-analysis looking at all the studies on auscultation, and they asked this question: is the stethoscope 200 years after its invention ready to be relegated to the museum shelf? Or does the stethoscope still provide some clues to aid in diagnosis? They looked at 34 studies and the 4 most common lung diseases. And basically they found similar things, like I mentioned, that these findings tend to be specific but not sensitive. But in pulmonary edema, they were neither specific or sensitive, only about 60%. And so what they concluded is that lung auscultation is not clinically useful in making the diagnosis in most circumstances, and that we must reconsider the use of the stethoscope in patient groups with low prevalence of disease, only in clinical situations where there's high prevalence of disease in very experienced hands, it may be somewhat useful. So if we fast forward to the POCUS era, now we have the ability miraculously to look inside the body, not just listen or kind of infer what's going on. On the left, we have a picture of the Butterfly IQ, which is one of the kind of bedside ultrasound tools that are new as of a few years ago. It connects to a smartphone and you can scan any organ, in real time. On the right is this, what's called the Sonocyte PX. It's what we have in the PCCU, and it provides really high quality imaging, and it's really portable for a single unit. But let's first focus on lung point of care ultrasound. This is almost entirely due to the work of Dr. Lichtenstein, that most people didn't even think lung ultrasound was possible because it's filled with air and ultrasound waves don't travel well through air. So until the 1990s, when Lichtenstein started showing and researching that, in fact, it is possible and incredibly powerful, nobody had any idea that this was true. So if we first take a step back and just briefly review some anatomy of the lung, here we have the left lung, the lobes. And if we zoom into one of the lobes, we'll see a lobule, which is basically the bronchioles, it's the blood vessels, and it's the alveolar sacs. And depicted with this white box is kind of the connective tissue around the lobules, which are called the interlobular septa. And normally they're dry, they're not filled with fluid, they're thin, they're smooth. And if we zoom in further into an alveolus, it looks something like this. And so if we look at the alveolus, we see this round structure with surrounded by these blood vessels where the capillaries and the red blood cells are, and this is where the gas exchange happens. Here we have this interstitial space, and normally there's about 500 mLs of what's called extravascular lung water, or just kind of fluid in and around the lung. That's normal, and normally your lymphatic system can deal with it. If there's a little bit of extra, it will remove it. And because of that, your interlobular septae are normally nice, thin, and smooth, and it causes no issue. And so if you place the ultrasound probe on a lung with these nice normal alveoli with nice thin, normal, smooth interlobular septae, you get something like this. And so this is where the ultrasound probe would sit, with the probe marker towards the head, and here's the probe marker. So in this image, the patient's head would be here, the feet would be over here. And the first thing you see is the connective tissue, the soft tissue like skin and adipose. You see an intercostal here, and then below that you see this bright line. And this is the pleural line. So what you're actually seeing here is the parietal and visceral pleura sliding on top of each other when the patient breathes. And while you may not appreciate it in this image, it's a little bit low resolution, but there's a shimmering appearance, or sometimes called ants on a log appearance, of normal lung sliding when the lung is intact. This is a normal finding, and it's a very important finding that we look for first when you're looking at lung. And then behind the pleural line in a normal lung, since it's filled by air, you will see nothing usually. And so what you're seeing here is actually a reflection of the pleural line, what Lichtenstein called the A lines. And it basically is a reflection of the pleural line. So up here, the ultrasound probe is sitting, and it's shooting out ultrasound waves. It bounces off here, bounces back off the probe, and then forms a reflection here, kind of like when you're in a fitting room, but between two mirrors, and you see infinite reflections of yourself. And so what Lichtenstein showed is that in normal lungs, you see A lines. And so this is incredibly important finding. This is essentially like the normal lung sounds you would hear if you listen to some of the normal lungs. But in pulmonary edema, things change. And so as Sir William Osler described it in his book in the late 1800s, in all forms of intense congestion, there's a transudation of serum from the engorged capillaries into the air cells and alveolar walls. So like I said, there's about 500 milliliters of extravascular lung water normally, but if you're filled with pulmonary edema, the capillaries engorge, and eventually more leaks out, and it eventually overwhelms your lymphatic system. And kind of like a clogged toilet, it just continues to overflow. It goes into the alveolus, it goes into the interlobular septae, And what you get is this kind of swelling and irregularity that forms. And as Lichtenstein described it in his textbook, it's this edematous and thickened subpleural interlobular septum surrounded by aerated alveoli creates this mingling of fluid and air. And this actually gives you a different artifact if you put the ultrasound probe on a patient with pulmonary edema. So in the same position as the previous patient, you put the ultrasound probe, and now instead of those horizontal artifacts you're seeing that are reflections, you're actually seeing these vertical projections emanating from the pleural line. And these are called B lines. And 1 or 2 in a rib space is considered normal, but if you have 3 or more, it's considered abnormal, and what Lichtenstein called lung rockets. So to be a B line or a lung rocket, it basically has to project from the pleural line and obliterate the A lines, be bright, and a few other criteria. But for the main part, if you have lung sliding and you have B lines like this in multiple rib spaces, it is essentially diagnostic of pulmonary edema with a few exceptions. So to summarize, you put the ultrasound probe on a patient's lung in any position, and on the left, if they have normal septae and normal lungs and not pulmonary edema in this position, you'll see a nice straight pleural line with lung sliding and A-line reflections. Whereas if they have pulmonary edema or other things we won't talk about in this talk, like pneumonia, you can have this picture where you have lung sliding and these diffuse B lines, and that's consistent with pulmonary edema. So most of this is out of the scope of this talk, but I just wanted to show that this is Dr. Lichtenstein, maybe his most important work. It's called the Blue Protocol, and he showed that if you apply this protocol to patients with acute shortness of breath without knowing anything else about them, with just using a combination of lung sliding, A lines, and B lines, you can pretty much get the right diagnosis almost every time. But in this case, we're really focused over here on the left side where there is lung sliding, and then you have this B profile, which is the multiple B lines. And so what do we know about B lines and lung rockets? Well, we know that the B line count correlates very well with the amount of extravascular lung water. So the more B lines you see, the more pulmonary edema there is. We know that in lungs without lung rockets, in other words, with the A lines, it's essentially diagnostic of normal extravascular lung water. We also know that as patients get more short of breath, their B lines increase, and as patients get diuretics or dialysis, their B lines decrease. And we also know that the number of B lines correlates quite well with the kind of gold standard of the left-sided pressures, or the left ventricular end diastolic pressure, which we'll talk about. So what about different studies around the world? Does this hold up? And so, for example, in a Canadian emergency department study, they found that lung sliding plus lung rockets was 92% sensitive and 85% specific, compared to a chest X-ray, which was much less sensitive. And this is kind of the pattern you see throughout. In an Italian study, it was very similar, 93% sensitive, 84% specific. In an interesting Slovenian study, they took 218 patients who presented to the ED with shortness of breath. They did a lung ultrasound exam, which they claimed was always under 1 minute, basically looking for lung sliding and lung rockets in multiple rib spaces. And then they also did the standard findings. They asked about orthopnea, they listened for rales, they measured a BNP. And then they looked at what are the odds of having pulmonary edema with any one of these being positive. And so for rales, for crackles, they found that if they found crackles, the odds that the patient had pulmonary edema was 5 times that of those who did not have crackles. For orthopnea, it was better. It was 6.9 times the odds of people without orthopnea. For BNP, it was 14, but for lung sliding with lung rockets, it was a whopping 53. And this corresponded with a sensitivity of 100% and 95% specificity. So in this study, they concluded that the ultrasound exam was actually the best method for confirming the diagnosis of acute heart failure in the pre-hospital setting. And since then, there have been multiple meta-analyses in 2014, 18, and 19 that basically found the same thing, is that it's very, very sensitive and specific, lung sliding and lung rockets for pulmonary edema. And in the kind of the cardiology literature, they also found quite interestingly that compared to the standard echo findings we use, really B-lines was by far the best predictor of elevated LVEDP. So they took 81 patients, ultrasounded their lungs, did a full echo, and then they underwent a left heart cath, and their kind of gold standard left-sided pressure, or LVEDP, was measured. And if you look here, for the patients with low LVEDP or under 20, on average, they had one B-line in all their lungs when they did a scan of all the lung fields. Whereas in patients with LVEDP that was high, over 20, they had on average 17 B-lines. And it was roughly 8 or more B-lines was roughly 90% sensitive and 80%, 78% specific for high LVEDP. And so it's not perfect, but they concluded that the B-line count was actually better than anything they could get from the echo, which was quite interesting. And to some degree, that makes sense. If you have high left-sided pressures, the fluid will back up into the lungs, and then that pulmonary edema will cause the B-lines. And so there's been 2 randomized trials of about 150 people, and basically they compared heart failure patients discharged from the hospital, and then they either did conventional physical exam down here, or they did a lung ultrasound physical exam. And based on the lung ultrasound findings, if there are 3 or more B-lines in multiple rib spaces, they would increase the diuretic dose compared to just the stethoscope, who would just kind of standard of care, and they did the diuretic doses as they saw fit. And they did show a pretty impressive reduction in risk for hospitalization, death, or urgent care visits. It was a relatively small study, but very similar results were found in another study that did almost the exact same thing. And they had improved 6-minute walk test. The ultrasound group gave more diuretics, probably because there was B-lines they were detecting that were not being detected with the stethoscope. And they had less urgent care visits as well. And so in this picture here, they're just showing how they kind of separate the lung into different quadrants and scan them. So they look for B-lines here, 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 and probably one on the back as well. And here is an example of multiple B-lines in a rib space. All right, so they basically concluded that lung ultrasound is an easy to use, highly effective method for managing heart failure patients. And so this is kind of a summary table from the book that really puts them all into perspective. So I think for a stethoscope and physical exam, overall, it seems like the sensitivity and specificity is quite low. Whereas chest X-ray, the specificity for pulmonary edema was pretty good, but the sensitivity was poor. Whereas for POCUS, it was as good as 97, 98%. So that's really a primer on lung ultrasound and how we use it for CHF patients in the PCCU. And next we'll talk about the jugular vein exam, which, as everyone knows, is a very iconic thing we learn in medical school, and it's done on every patient with presumed heart failure. And it was first described by Sir Thomas Lewis. He was a cardiologist. And in 1930, he published this paper called Early Signs of Cardiac Failure, where he described his method. And it was very qualitative and kind of primitive, but it was brilliant in that he figured out that, if he saw the jugular vein and it was distended, the higher that it was distended, he felt the higher that the pressure and the more congestion the patient had. And that's really been the technique we've used ever since. This just a summary of it. Basically, like I said, like everybody probably knows, you look at the lateral portion of the neck, you're looking for the internal jugular vein, and you're looking for the highest point at where you see the jugular venous pulsation. And so let's say it's right here. And so you see that, and then you measure the vertical distance from that point down to the sternal angle or roughly the clavicle. And that's your pressure in centimeters of water for what I call the visible portion of the jugular vein. All right, and then since you can't see below the sternal angle, and you don't really know how low the right atrium is, we classically assume that it's 5 centimeters deep. And so you add 5 centimeters to whatever your initial estimate was, and you get the jugular venous pressure, which should roughly equal the right atrial pressure. And the reason that's so important is right atrial pressure correlates quite well with elevated wedge pressure, which correlates with left-sided pressure. So we're basically looking at the right-sided pressure to estimate the overall fluid status of the patient, right? But if you look at actually the studies that have assessed how accurate this method is, they're not very good. I mean, as far back as 1974, and in Northwestern, they did a study, and interestingly, they had trouble seeing the internal jugular vein, so they couldn't even use it, and they just used the external jugular vein. But even with that, they decided that you can't really reliably estimate central venous pressure with an eyeball exam. In a New England Journal of Medicine study of ICU patients compared to a right heart cath, they found it was better than random, but they're only about right 42% of the time. In a 1990 ICU study, very similar results. In the ICU, they couldn't accurately detect elevated pressure. In a group of cardiologists in 2007, they found that if the column of blood was distended above the clavicle in the sitting position, it was only 65% sensitive and 85% specific for elevated pressures compared to a right heart cath. So some more similar evidence in medical residents, they were only 14% sensitive at detecting elevated JVP. An intensivist, a study of intensivists with a training session beforehand, they still were not very good at detecting it. So this really brings us to what are the limitations of our physical exam without ultrasound. And I think there's really two of them. One is if you can't see the meniscus, you can't measure it. So, there are multiple scenarios where you can't see it no matter how good you are at the exam. One is if the pressure is so high that the meniscus actually resides above the mandible, if you look at the neck, you're not going to see any pulsations. The other thing is if the pressure is so low, it's below the clavicle, you won't see any either. So you can't really differentiate sometimes if it's incredibly high or very low or normal. And the other thing, as all of us have probably experienced multiple times, if the patient has a very thick neck, if they're obese, if they have a large beard, it's very difficult to see the jugular vein at all. The second limitation, which I think really limits all of the studies up until this point, is the assumption that the right atrium is below 5 centimeters below the sternal angle, when I would argue that's usually not. And it took me a long time to figure out where this 5 centimeter thing came from. And I finally found it. It was a 1946 study in New York where basically they put a pressure sensor on a urinary catheter. This was in the early days of right heart caths. And they basically weaseled the catheter up into the right atrium. And then they laid the patient flat and took an x-ray. And then they tried to measure the distance from the sternal angle down to the atrium. And they basically said that it was about 5.8, but for the sake of simplicity, it has been decided to take the conventional venous pressure reference level of 5 centimeters below the angle of Louis. Now, it's a reasonable estimate, I suppose, but if you look at more modern studies where they actually measure it on CAT scans, it's really very unlikely to be 5. This was a study in Canada from 2002 where they did CAT scans of a bunch of patients, and they just measured the distance to the center of the right atrium, and they found that it was all over the place, but it tended to center probably around 9, but it was anywhere from like 4.5 to 15 below the sternal angle. And then in a more recent study, they took 180 patients getting a right heart cath, and then they did CAT scans, and then they just looked at the different zeroing techniques that the interventionalist used and how often those actually correlated with the center of the right atrium. And so if you look at this first line here, the kind of classic thing we do on the physical exam, 5 centimeters below the anterior thorax surface, only 29% of the time was actually in the right atrium. 1/3, so going deeper down, 1/3 of the chest, it was 98% of the time was in the right atrium. And they found on average, just like the previous study, that about 9 centimeters was the average of depth to the center of the right atrium. And this highlights another important point, is that when we look at right heart caths, it actually makes a big difference on what the interventionalist uses, because if you use the 5 centimeter rule versus if you use what apparently some use is 10 centimeters above the table, you get dramatically different results, and I'll show you that. So, the reason the 0 point is so important is, like I said, if in this study, they looked at how the wedge pressure and other pressures would change if you use different zeroing techniques. And so if you use the standard method 5 centimeters below the surface of the sternum, they found that 7% of their patients had elevated wedge pressure. Whereas if you went to the mid-thoracic, it bumped up to 22% suddenly have the same patients, but now they're suddenly categorized with an elevated wedge pressure. And so you can see that clearly the zeroing technique has a large effect on the resulting pressure. And so with those arguments, in my opinion, the only way to calculate an accurate right atrial pressure at the bedside is to first visualize the jugular vein in every patient, and second, measure the right atrial depth in every patient, which up until now hasn't really been able to be done at the bedside. And so if we want to visualize the internal jugular vein in every patient, it's really quite easy with ultrasound because the jugular vein sits so superficial in the neck that it's essentially visible in every single patient, no matter how obese they are. And this is a kind of a schematic of what it looks like. So the internal jugular vein is on top of the carotid artery. And at the meniscus, or at the top of the blood column, it takes on this triangular appearance right here, which was called in the literature, one person described it as the top of a wine bottle. And so I kind of coined it as the wine bottle sign, which I guess looks kind of like it. And below that is the carotid artery. And so this is what it looks like in real time. So in this is the longitudinal or head to toe axis. You can see here is the triangular appearance of the meniscus. And then below it that's when the patient coughed. And then below it is the carotid artery. So you can really accurately see the meniscus, which is pretty cool. And if you look at the transverse view, or the left to right axis, you can also see it. So this is actually probably a little bit below the meniscus because it still engorges a lot, but it collapses completely. So you know that you're close to the meniscus here, and this is the carotid artery. So the second part, as I mentioned, is that we really need to be able to measure the right atrial depth in every patient if we want to get an accurate JVP, or right atrial pressure, at the bedside. And so I had this idea that, if you look at this, and you don't need to understand this image other than to say that this is the aortic valve, and this is the non-coronary cusp. And if you look, it is sitting right in the same coronal plane as the right atrium. And so if you then acquire kind of the standard first echo view, what's called the peristernal long axis view, which is relatively easy to get, and especially in a patient lying on their back, if you measure down to that point, which is right here, this is the non-coronary cusp where it attaches to the back wall of the left ventricular outflow tract. If you measure to that point, you're really measuring to the center of the right atrium, or at least that was my hypothesis. And so that resulted in this study that's now in the preprint server awaiting publication. And basically what I found was that in many of the patients, this method was almost exactly correct. And then in other patients, it was way off. And I could not figure out why until towards the end of the study, I started noticing that when I would do my technique and compare it to right heart caths with certain interventionalists, it would be right. And then when I would do it with others, it would be wrong. And so I think that eventually I figured out that kind of speaks to the zeroing techniques that different interventionalists may be using that are resulting in different results. And so that was my hypothesis for the second study. So I teamed up with Dr. Joe Kiernan, one of our interventionalists, and we're doing a second study to try to figure out if that's the case. And so far, the results are quite good. And I just wanted to go over a few cases with you, but basically this is the framework. And so you basically measure the right atrial depth, as I said, and then that's the first step. So in the peristernal long axis view, you look for the posterior wall of the LVOT where it connects to the non-coronary cusp. That's your first measurement in centimeters. Second, you look at the supraclavicular point, which I'll show you, with the patient at 45 degrees, and you gently rest the probe just above the clavicle, all right? And then you're just looking for JVD. If JVD is present, and that's defined as a distended jugular vein that's not collapsing with inspiration, that means that there is JVD and the pressure is higher than that. So then you slide the probe up the neck to look for the meniscus or the wine bottle sign. And in those cases, right atrial pressure is essentially the right atrial depth plus the distance to the wine bottle sign. If the JVD is absent, in other words, if the JVD is completely collapsing, then you lower the bed to 30 degrees, do the same thing. If it engorges at 30, then you can estimate the right atrial pressure as right atrial depth times 0.75. If it doesn't engorge, you lower the bed to supine and then do the same thing. If it engorges at supine, it's right atrial depth times 0.5. If it still doesn't engorge, then it's probably right atrial depth times 0.25. So let me just show you some cases. So this is a patient with amyloidosis, and basically you put the probe on the patient's heart at 45 degrees in the peristernal long axis view like this. And this is what you'll see. And so here's the left atrium, left ventricle, here's the aortic valve. And you can see it's a little bit of a hazy image, but you can see right here is the non-coronary cusp, and it's attaching to the LVO2 about here. So I'll say the right atrial depth in this case is about 8 centimeters. So the second thing is you put the probe in the transverse view just above the clavicle and rest it on the patient's neck. And this is when the bed is at 45 degrees. And so in this patient, you see the IJ, the internal jugular vein here, is distended. And as the patient's breathing, it is not collapsing like it should be. This is the carotid artery. And so we know that we have JVD here. And so if we go to our algorithm here, so we know we have JVD. So now we're going to find the wine bottle sign. So we slide the probe up the neck 4 centimeters, and we come to this point here. And that's the collapse point, as we mentioned. That's the wine bottle sign. And so I measure that with a ruler at 45 degrees. So that's 4 centimeters. And we know the right atrial depth was about 8 centimeters. So that's 12. And then you have to convert it to millimeters of mercury. So it's about times 0.78 or so. And in this case, we got 8.8. And then the actual right heart cath was 10. So here's a second quick case. Again, you get the peristernal long axis view. Here is the non-coronary cusp. Here is the LVOT. So I said it was about 9 in this patient. And then we do the supraclavicular point. And here you see the carotid artery here, but in here, the internal jugular vein is completely collapsed at 45 degrees. And if you ask the patient to cough, you'll see that it'll expand. So right away, you know that if they Valsalva and cough and it expands that much, you can be confident that the right atrial pressure is probably normal. But in this case, if we go back to our algorithm, the JVD is absent. So now we lower the bed to 30 degrees. So let's lower to 30 degrees and we look, and the vein is still basically collapsed. It does open a little bit when they breathe, but it's basically completely collapsed. So it still hasn't engorged. So we lower the bed to supine. And now you see the internal jugular vein engorge here. And so then if you go back to the algorithm, we have the right atrial depth of 9 centimeters times 0.5 because it engorged at supine. You have 4.5 centimeters, convert it to millimeters is 3.3. And this patient, the pressure was actually 5. So the study is underway, but we're pretty confident that this method is quite good at getting a right atrial pressure plus or minus 2 or 3 millimeters of mercury. So lastly, and most briefly, I'll just talk about the cardiac exam and CHF and how it's evolved over the years. So it's basically been an elusive diagnosis to some degree of saying this patient has reduced reduced ejection fraction or congestive heart failure. I mean, even before Lennec, they knew all the signs and symptoms. Lennec knew that in these patients, they had a, quote, habitually swelled state of the veins. Dr. Hope, the first cardiologist that I discussed earlier, he really had like perfect descriptions of CHF and the manifestations that he described and anasarca, and it was really impressive to read. But they could only infer, what was going on with the heart. They couldn't really figure it out until the patient died. And then a little later, this French cardiologist figured out that in heart failure patients, they may have this extra heart sound, the S3, which we have all learned about. And this is how he described it: 2 normal sounds of the heart and a super added sound. This is the bruit de Gallup. But if you look at the literature, it's very hard to say how accurate it is. The early studies, probably when people were much better at cardiac auscultation, were better, but more recently, they're very, very poor. There's also a lot of inter-observer disagreement. Like if two doctors listen to the same heart, they may not agree that there even is an S3. But ultimately, all this stuff is just inferring what may be going on with the heart. But fortunately, in the POCUS era now, we can just look and see what's going on. And so this was really the cardiac POCUS pioneer that I mentioned, the Dutch cardiologist. And as far back as the 1970s, he was doing bedside ultrasound. And he had a famous quote 1 year before he died, where he said, "Future generations of doctors will find it hard to believe that in 2013, many clinicians were still relying on the vague findings of a 200-year-old traditional physical exam and were compromising clinical efficacy when direct information was available from point of care echo. History will undoubtedly show that point of care echo was the beginning of a new glorious age of physical exam." So this is just a clip from his study, and this is them scanning someone's abdomen with this kind of prototype of a ultrasound, bedside ultrasound device, where they would look in the image here, and this was the transducer. And they were able to see pretty impressive things for 1978, the size of the ventricles. They were able to diagnose pericardial effusions. And we now know that, there's a lot of literature that says, non-cardiologists can at least qualitatively estimate the EF quite accurately. And you can see here on the left, we have a normal EF or maybe a hyperdynamic EF, and the ventricle is contracting symmetrically and nicely, and the anterior leaf of the mitral valve is snapping open. And these are things that are not the case in a patient with, severely reduced ejection fraction, where you can see here the valve is barely opening, the walls are barely contracting, and they're very dilated. And so the last thing I'll mention is this kind of was summarized quite nicely in a study that cardiologists did in 2005. And they said, well, with the oncoming technology and the ability to do ultrasound at the bedside now, like how good is it compared to an experienced cardiologist with a stethoscope? So they really took the most extreme example. They took first-year medical students who have never seen a patient clinically. They gave them a handheld ultrasound. They gave them 18 hours of training. And then they took patients with known cardiac, clinically, quote, significant cardiac disease of various kinds. And they blinded the clinicians and said, try to figure out what's going on with these patients. And, what they found was pretty striking. The students were able to identify 75% of the pathologies, while the cardiologists found half. The students only missed 4% of severe cases, while the cardiologists missed 32%. The valvular disease, the students detected 90%, while the cardiologists detected 50%. And the lesions that produced the diastolic murmur, the students detected 76%, while the cardiologists only detected 16%. So they basically concluded that, medical students with a minimal training in ultrasound were better than board certified cardiologists at performing these physical exams. And, they said it's really not a deficiency of any clinician or cardiologist. Really, they're just inherent limitations in using a stethoscope, palpation, percussion, things like that. And so this was really confirmed in another study from 2014, where they showed that adding POCUS in a blinded fashion dramatically improved diagnostic accuracy for, major cardiac pathologies. And so the last couple of slides here, what are some challenges to wide adoption? Well, there's really not a great way for people to get trained right now. There's a great certification through Chest and Society of Hospital Medicine, where you have to go to multiple conferences, do online courses, submit images to people to review. And it's really excellent, but it's pretty expensive, and it takes a long time. Not a lot of people are willing to do that. Also, the cost of an ultrasound probe, now with the kind of handheld devices like the Butterfly and others, the price has dropped about 20, 30x from the big machines, but it's still very significant compared to a stethoscope. There's also a lot of difficulty. I mean, people have been using a stethoscope for decades, and to ask them to suddenly change and learn a new technique, understandably, garners up some anger or frustration or whatnot. So there's definitely still limitations to wide adoption, but I think the evidence is clear that it's better. It's just a matter of how do we get people to use it. So in summary, I think a lot about what Dr. Lanek, what Dr. Hope, and others would say if they were alive today and saw like a basic bedside ultrasound image, for them to figure out this stuff took weeks to months for one patient. They basically had to wait for them to die and do an autopsy. And what the guy that translated Lanek's work into English, he was a doctor named John Forbes, and one of his quotes was that Lanek had achieved the wish of the ancient philosophers to place a window into the breast through which we can see the precise state of things within. And of course, this was the audible state of things within. They couldn't see actually what was going on. But, now with how easy it is to get an ultrasound image of the real-time image of what's going on with the heart, it would just be amazing to see what they would think now, of course. So I'll leave you with the last question of why do we continue to infer what diseases reside within the chest when we can look inside and know for sure? So that's all I got. So I'll open it up for any questions people might have.
Thank you very much, Dr. Istrail. That talk was excellent. I see there are also already some raised hands in the chat here. So I'm going to allow everyone to unmute themselves and ask questions over Zoom rather than in the chat. But if I first just read out something from Dr. Denani, who said, very timely and impressive work. Thank you very much for contributing to the improvement of care in this field and the hospital. And Dr. Woods as well, who had to jump off, said that it was a great job and fantastic talk. So let's hear some of these questions, starting with Dr. Meyer.
Yes, thank you very much for that interesting talk. I started echocardiography in the 1970s at GW, and I did the echocardiograms myself for about a year, but then it became too burdensome, and I trained echocardiographic technologists. And of course, with the increasing technology with 2D and Doppler and so forth, it was difficult for me to upgrade my so-called knobology because the machines are so complicated. So basically, I would read echocardiograms, but I would not do them. It seems to be very technically difficult, and the person who's doing 10 a day is more likely to be able to obtain a good picture. I was wondering how difficult is it to train people who are not doing these every day, many per day, to actually get good pictures?
Yeah, it's definitely an issue. I mean, like I said, there's a certification process that I underwent, and for cardiac images, you have to submit 25 images of each view of the heart, so 100 total. And then you're modestly good at it, but then you of course get better with experience. Yeah, so that's definitely a concern, and I think rightly so. We shouldn't just let anybody who's never done it before just stick an ultrasound probe on a person and try to diagnose cardiac disease. But at the same time, one of the kind of pioneers in POCUS, his name is Neelam Soni. He's a hospitalist, and he wrote kind of the textbook on it. And I interviewed him in the book, and he made a really good point, which I never really thought of, is like, between 9 and 5, Monday through Friday, yes, there's echo techs, there's cardiologists, there's everybody you could imagine. But at 5:01 to 7 a.m. the next day, it's not so easy to get echo tech at the bedside in minutes or hours if you're really concerned about something. So, POCUS is really amazing in that regard. But just in general, yeah, I mean, if the techs can learn how to do it, I don't see why a physician or a clinician or a PA or NP couldn't learn with appropriate, image approval and quality assessment, things like that.
It's just a matter of whether they would have time, because of course your comparison should really be the cardiologist and an echocardiogram done by a technologist.
Yeah, of course, but we're not also, POCUS is not, measuring the degree of AS or the velocity or the valve diameter. It's really, like I said, answering focused clinical question. Is there a reduced EF? Is there a pericardial effusion? Is there like severe MR, things like that, that you could qualitatively assess? And then, obviously as people get better or more skilled, like someone like Hussein Danani could do a lot more advanced echocardiography than I could do, or most people. So I think there's a degree, but also I would say auscultation should have the same criticism to it. Nobody knows what people are listening to when they listen to a heart. Nobody knows how accurate your ears are to detect actual murmurs and if you're correct or not. We just kind of assume. So I think the same critique could be applied to that.
That's true.
Thank you. There's a question from Dr. Danani.
I was actually responding to Dr. Myers' point and to Larry. Machines are not as complicated as they used to be. They're more complicated on the inside, but knowledge has significantly improved now with the years. And if you look at the butterfly IQ probe, there's really no knobs. It's just a probe and a window. And if you want to change something, you just put your finger on it and it changes. That's just an extreme example of how simple things have become for the operators. Of course, the butterfly IQ probe will not measure the, inflow velocity variations and all that Doppler stuff that I tend to want to look at. So I tend to use a slightly more sophisticated machine when I'm looking at patients. So that's to your first point. And I appreciate that you're a huge pioneer in ultrasound of the heart in this area, and we appreciate the service of people like you, and now with people like Larry, doing what you're doing. It's really breaking through that barrier of people's attitudes about staying stuck in the way we've always done things. I just feel that I examine every single patient I see with ultrasound, and I don't use a stethoscope anymore. Every organ system gets ultrasounded on every patient. So I'll just leave that comment. And Larry, thank you so much for everything you've done. This is hopefully going to herald a change in the attitudes towards physical exam and clinical care in general at Fairfax.
Thank you. Thank you.
I think Dr. Greenspan has a question.
Yeah, excellent presentation of auscultation and ultrasound in diagnosis of congestive failure. I was wondering if there's any role of taking a history in CHF. Hostler once said, listen to the patient, he will tell you the diagnosis. What would you respond to that?
Of course. I mean, this is not replacing the physical exam. It's funny, I wrote an article about this during COVID 22 years ago, and the comments I got were so incredibly angry. I was surprised by, I guess maybe I didn't explain it properly, but I think there was an assumption that this is like a technophile's like happy day, and you don't even talk to the patient anymore, you just send them for a scan. But of course that's not the case. I mean, I just look at it as a stethoscope or internal inspection. You would talk to the patient if you can listen to their heart and they have 2+ pitting edema and they have JVD to their earlobe. You would still ask the history, so I don't see how it's any different.
If anything, it brings you closer to the patient. You're actually putting your hands on the patient now. So while you're talking to the patient, you're listening to them and you're actually interacting with the patient and you're showing them the picture of what's going on in their body. And my experience with the patient interaction is that has increased the intimacy of a patient interaction and the trust that the patient has on the doctor by orders of magnitude.
There's actually studies in Denmark that I talk about in the book where they basically asked 600 or something patients, how do you feel about POCUS? Because they were doing it in an outpatient clinic, and basically they all loved it. They felt like the physicians spent more time with them. They explained it better. They understood their disease better. So I think, I think that's kind of a concern that may not come to fruition, really.
I think I'm sorry, I should raise my hand.
Yes, go ahead.
All right. One of the issues, it's interesting because I recently brought this up with my PCP because I have family in Europe and they all get POCUS when they go to see their primary care physicians and they love it. Not only that, but we've actually had family members who were diagnosed with preliminary tumors and that they were treated before there was metastasis. And so I asked my PCP why we don't do it here. And she said it's because of the insurance. She's like, A, we are not trained in it, but how do we bill for it? And I think in the United States, this becomes an issue. And as one of the people pointed out, the time that it takes. Hussein is very adept at doing POCUS, and he goes from room to room and certainly ultrasounds all the patients, which is great. But I'm much slower at it, and so I reserve my very rudimentary skills for patients who are, as you said, between 5 p.m. and 7 a.m. I don't have a better set of hands and eyes to look at my ultrasound image, and I will certainly focus them. I think it's definitely the world of medicine is going towards this, and there is always a resistance among our kind when we are exposed to newer technologies, because there's a lot of pride in the art of medicine. And I think a lot of times, including myself, there's a hesitation to adapt to the newer trends of the art that we practice.
Yeah, I mean, if you read, I wrote about this a lot in the book. If you look at like what people thought of the stethoscope when it first came out, I mean, majority of doctors thought it was stupid. There was a famous quote where they're like, this is more useful for a pathologist than a clinician. There was huge ridicule of this. And, I feel personally like this is the same thing that's happening. The idea that we're not doing it because insurance doesn't make sense to me, because we listen to people's hearts and lungs with a stethoscope without insurance. I think definitely, like you said, Asma, is like, we don't have a training component built in. So if you didn't do a fellowship in POCUS, or you didn't learn during residency, or you didn't do a certification, because most people don't have the time to do that, it's very hard to expect someone to do like a longitudinal course. And so I think that's definitely one of the barriers for anyone who wants to do this, or to learn how to do it. So
Thank you. I saw a question from Katie Cummings. Did you still have a question?
Hi, Dr. Istrail. I just had a quick question about what you feel is a limitation of the POCUS exam, like for all of us who could be potentially using this technology in the coming years. I think understanding the weakness of it is really important in its primary use. So have you found anything with POCUS that that you feel that you missed, or you just have higher level of suspicion for when you're doing the exam?
yeah, I mean, it's definitely not like the panacea that diagnoses every disease under the sun. Lichtenstein, the guy who figured out lung ultrasound, he talks about that in order to see anything in the lung, it has to abut the pleura in some degree, so that there's a ultrasound window. So if you have some like small mass or pneumonia that is kind of central in the lung, or in like maybe the hilar region or something, you would definitely not see it. He argues that that's 97% of the time that it abuts the pleura at some point. But yeah, like for PEs, you can't diagnose it with certainty unless you see certain signs. I mean, there's lots of diseases where it's not great and you need other imaging. Obviously, brain imaging is encased in the skull, and there's limited amounts of POCUS you could do there. There is some, but so I think what's important is, whether it's the stethoscope or the ultrasound or the CT scan or the chest x-ray, it's knowing the sensitivity and specificity of each. I mean, until I looked into this, I didn't know that a chest x-ray, like how bad it was in many things. When I started scanning patients where every other one has pneumonia, then you look and there's no pneumonia, there's like a big pleural effusion. So the chest x-ray has enormous limitations, but POCUS does too. So I think what's most important is saying, all right, this has 80% sensitivity or 100% sensitivity, therefore if I do it and I don't see what I'm looking for, I can be confident it's not there, or vice versa.
Thank you. A couple of comments from the chat. Excellent talk. Dr. Di Filippi said, wonderful presentation, and looking into their fellows getting training. Dr. Casrabata, great talk. There's a question, does an electronic stethoscope increase clinicians' findings?
I mean, I'm sure it does. I mean, you can hear more, but then again, it comes back to, like, I have a whole section on cardiac auscultation in the book, and long and short of it is very similar things as you saw for lung. The signs are specific but not sensitive. So if you go and you listen for a classic AS murmur and you hear it, then it's very likely to be accurate. But if you don't hear it, that doesn't necessarily rule it out. Same with mitral regurgitation, tricuspid, the S3s and all that. So certainly, if you can increase the volume of the murmurs, maybe that would increase the sensitivity. I don't know, but I still think there's inherent limitations with listening. I mean, it's like watching a basketball game on TV and then listening to it on the radio. I mean, no matter how good the radio announcer is, you're not going to get as much information.
I like that comparison, Dr. Shaw. I think that might be all that we have time for.
Right.
Thank you very much for coming and talking to us. And we'll see everyone next week. Thank you.
Thank you. Thank you, everyone.